we used to joke around in our training days. Like God comes and says, I'm going to give you one cancer. You have no option, choose one. Then prostate cancer is the one what we choose.
And by the time the bladder tumor comes to us, we already have resected it. It has already become muscle invasive, and when we can't deal with it, we push it on and take care of it now.
And then I tried intermittent fasting, didn't help me. I tried the Mediterranean diet, didn't help me.
Like when I was also trying to lose weight, I tried idli. Idli was not helping.
Idli doesn't help at all. Hi everyone, welcome to the second episode of Beyond Medicine by Arete Hospitals, where we'll be diving into real conversations which are often overlooked. And I'm Dr Saadvik, medical oncologist at Arete Hospitals, and joining me here today is Dr Khizar, a prominent urologist with extensive expertise into men's health.
Thank you for having me.
So Dr Khizar, what I've noticed is my personal experience. Now, a lot of men, they usually don't come and discuss their sexual issues or mental issues very openly. And most of the time, by the time they even reach to the doctor, they'll be already using a lot of medicines on their own. What could be the reason that they're not so open to such discussions with a doctor who's actually qualified to help them out more?
So basically the problem begins with the male ego. At first, the patient himself feels embarrassed to discuss it with the doctor or a family member. Either it's Google, or it's the local pharmacist, or it's just a friend, and you don't know the authenticity of the information the friend or the person is giving to that person. So first is embarrassment. So to overcome that and for the patient to understand that he has a problem and to understand that he needs to approach a doctor is the first step. Once he takes that step, it's the easier part of the treatment. But for the patient to take that first step is very important.
Do you think if the parents start this conversation at a very young age, will that bring about some change in their mindset and being more open to approach a health professional rather than depending on friends and pharmacy people for their problems?
Usually what happens is patients, especially younger generation of patients, like who are approaching puberty or who have problems, they don't like to discuss the problems with the parents. So sometimes they usually go to uncles, aunts, siblings who are closer to them, or cousins who are they're slightly elder to them or more close to them. So they would be a bridge between the parents and the patient who can help us to get the patient to the doctor.
And somehow they associate with this with their masculinity. How do they accept this once you start discussing with them in your OPD, saying this is the problem and whether this can be treated, whether this cannot be treated? And how is their mental health overall once this
again firstly it comes down to male ego first. To extract it from the patient that he has a problem is a big task for a urologist itself. So you have to give the environment and the comfort to the patient to open up and tell what he wants to tell to the doctor. And coming to the mental health, 90% of sexual problems, especially erectile dysfunction and premature ejaculation, are psychogenic. And there is also a digital aspect to it, but 90% of it is psychogenic, and which is reversible, especially for the younger generation of the population which is doing graveyard shifts, who has a lot of stress and who do not follow a healthy lifestyle and diet.
And in your experience, have you anytime seen that non-allopathic medicines working for these sexual conditions what they have?
When you listen to even claims on Instagram and social media, you would be surprised the amount of success rates these non-allopathic practitioners claim to have. That is just not possible. So as I said, 90% is psychogenic. So they play with the mind, they give some kind of medication, and the patient feels that he is taking medication for it and it is working, and placebo effect, and it works.
Yeah, because even as an oncologist, I've seen a lot of these centers blooming up. There is something called immunotherapy in oncology, what we use quite often for most of the malignancies. with very good results in most of them. Now a lot of centers have propped up in the city as well, where they're selling immunotherapy medicines in a box, which is oral medicines, and which is not DGCA approved. There is no scientific evidence, there is no clinical trial which has been done for that, but they play with the mind of the patient, as you said, saying this will work 100%, especially in that moment when the patient gets a diagnosis of cancer. It's very fragile. So at that point of a time, it's very easy if you say things like it's 100% cure, you don't need to be worried, rather than being more realistic about it, that what are the chances of cancer getting better. So I've seen many people getting attracted towards that. So that is why I specifically asked, how is your experience with these?
Yeah, the same thing happens. They go, it's an off-label drug. It's in a form of a halwa or a powder or something you mix with water and drinking.
Yeah, sure.
Or it's a form of some capsule which you just gulp it. You don't know what is in there. And the patient feels that he's being treated for it, and sometimes it works like a placebo, sometimes it doesn't. But 90% is psychogenic, especially for the youngsters, and they have to understand that it is reversible without any medication, and with just healthy lifestyle and healthy health practices. So they should make sure that the source they're going to is correct, and the advice they're taking from the person should be correct and experienced.
So you're saying like not all sexual problems what men face need a medicine. It can be reversed even with lifestyle changes. So coming to lifestyle, I know you even before, I think even you're into a healthy lifestyle.
Yeah, definitely. Like as the more weight you lose, it is the single most advantageous factor for confidence. That you also
correct, mental confidence.
That as soon as you lose weight, confidence goes up,
yes,
performance goes up, every aspect of your life, not just sexual health, every aspect of your life, your level of, even for me, the more weight I lose, the level of surgery goes up. So it is like definitely a factor which affects your health, total holistic well-being.
And now with modernization, as you're saying, like a lot of stress can also lead to these problems. So what are the numbers like? Like how common is this these days?
Two things I would like to address here is, one is erectile dysfunction and one is premature ejaculation, which the younger generation is suffering. And I would attribute a lot of this to pornography. Because they've worked graveyard shifts or have relationship issues and resort to pornography, the level of premature ejaculation has spiked. And to bring them down from addiction to medication, then taking them off medication is a bigger task than just erectile dysfunction. Erectile dysfunction is easier to treat, but premature ejaculation with pornography addiction is very difficult. So youngsters especially have to make sure that the West is already talking about it, and we have to understand that pornography is addictive and is like a drug.
And you've been very open about it. And even if you look at a lot of social media content or online written content, there's very less spoken about men's health. Most of the content you see gynecology, gastro, cancer related and everything. And I've seen very less amount of urologists coming out and talking about androgenic care and sexual health and these things. What could be the reason behind that? Even the doctors feel uncomfortable discussing that?
I think the urologists in India are blessed with a lot of stones to be to be handling. So very few urologists come out and talk about andrology, and there's no holistic approach to it. So suppose even if a patient comes with complaints of ED or premature ejaculation, they would just prescribe a medication, ask the patient to take it, and see if it works, come back and review. But they don't try to get to the root cause. Okay, why did the patient start it? Is he addicted to pornography or not? Why is it happening at a younger age? Is there a factor of probably hypogonadism? Is there a factor of obesity or hypothyroidism, which you as a urologist are so busy that you sometimes miss it out. But I think andrology in specific, especially in young patients, more attention has to be given to the causative factor, and the causative factor being treated, the patient becomes normal very quickly.
So what I could understand by this conversation is, like, not all patients will be needing medicines, and most of them are reversible problems, and if you are able to maintain a healthy lifestyle, then chances of getting into these problems is also much less. This
Yeah.
is what.
Whenever a young patient comes to me, anybody less than 35, I tell them to go on an active lifestyle, come back after a week and tell me how they feel. Then I would want to give them a medication. Unless until they're really struggling with problems in their relationships. If they want something SOS, then I give it to them. But I advise them to go on at least a 10-day stint of an active lifestyle and a healthy diet, see the difference, and then take the medicine and see the difference, and 1 + 1 is equals to 3, and they feel better, and they also feel the confidence that it's not going to be lifelong and the drug is going to come off, and then it's going to be just their lifestyle which is going to be lifelong. Coming to male health and cancers. So what everyone is worried about nowadays is prostate cancer. So let's talk about prostate cancer first. So what would your take be on a patient who walks into the clinic, 40 years of age, and what would you advise?
See, prostate cancer, like you have to see how the West is doing and how India is doing. West and worldwide, it is the second most common cancer among men. But in India, it is still trying to reach the top 10. There's multitude of reasons for that. West had adopted a screening strategy initially. They were screening people for prostate cancer. Later on, they found that's not such a good idea and they stopped it. India, we don't really do screening for prostate cancer. And if I have a 40-year patient with me in my OPD, prostate cancer is not the first thing I'll be thinking about for him. Because prostate cancer is mostly in disease of the older people, at least 65 years and above. These are the patients who will be more prone for prostate cancer. But saying that, it is not like a dictum rule that only those age groups will get the cancer. There are certain patients who may be at high risk, like if there are any genetic abnormalities in them. Most commonly what we keep discussing these days is about those BRCA1 and BRCA2 gene mutations. And most of the time what is highlighted is breast cancer in them. But you have to be aware that even male can have these genetic abnormalities, and if they have these genetic abnormalities, they are prone for prostate cancer as well as other pancreatic and other cancers. But apart from that, these are not the only two genes. There are many other genes which can result in prostate cancer. Another thing is Lynch syndrome, which mostly the gastro team will be seeing it, because though people with that syndrome have higher incidence of intestinal cancers, colon, rectal cancers, and in female uterine cancers. The unfortunate thing is in male, apart from the intestinal cancers, they're prone for prostate also. So if you have someone like a high risk, then yes, 40 years also I would like to check. But apart from that, no. Usually, commonly what we see is in elderly people, 60, 65 years and above.
Why I asked you is because now in the master health checkups, PSA is also included. So suppose a higher PSA, anything above 4 comes in, and patient gets scared. So obviously we know that it's slow growing cancer. Like even if it comes out as adenocarcinoma, even younger patient, it's still very treatable. Very one of the cancers you would probably choose to have rather than compared to any other more aggressive cancer.
Yeah, we used to joke around in our training days, like if God comes and says, I'm going to give you one cancer, you have no option, choose one, then prostate cancer is the one what we choose. Because the biology of the cancer is as such, and the advancements which have been happening of late also, that has led to a marked shift in the outcomes of prostate cancer patients. If you say 10 years back, probably a prostate cancer patient who was stage 4 could live for around 2 years maybe. Now even such stage 4 prostate cancer patients with a very good quality of life, like looking at them, you will not be able to say that they are cancer patients. They'll be living for 4-5 years. And coming to the PSA, that's a very interesting thing. All the master health checkups, they have PSA in them as part of the package. But what thing we should remember is a raised PSA does not always mean that it's prostate cancer. There are many other conditions where a PSA can be raised, like if there is any inflammation of the prostate or sometimes urinary retention which happens, which oftenly they come to urologists for. And elderly people as they age, like they have a condition called BPH. And for elderly people, as the prostate size increases, the amount of PSA secreted into blood is also different. So they may have mildly elevated values. So always seeing a PSA high value, you should be alarmed at it, but not conclude that it's a prostate cancer. And now there are a lot of advancements also in PSA testing, and I'm sure you'll be aware of it. So the logic behind that is whenever there's a PSA which is there are two types, to put it simply. One is the free PSA, and other is that gets made into inactive PSA. So what we find in our blood is inactive PSA which comes out. But whenever there is cancer, because the cellular architecture is completely destroyed, a lot of free PSA will get leaked into the blood. So in cancer, you'll have a lot of free PSA as well. So when you have a PSA which is doubtful, like 4 to 10 range, less than 4 you consider normal, most case scenarios. 4 to 10 is where you have a dilemma, whether we should go ahead and do a biopsy or should we follow it up, and because it will be a point of anxiety for the patient as well. So that is where you can use these other modalities, like check the free PSA value, check the ratio, that may give us a hint whether it is malignant or a benign condition. So things like that.
So coming to the treatment modalities, we have a plethora of modalities coming from hormonal manipulation to surgery to surgical castration. So when you get a patient, say about 50-60 years of age, no symptoms, just shows a high PSA, so you still want to go aggressively with the patient, or you would want to put the patient on surveillance and then keep a track of the patient? What is like your strategy for the Indian scenario with a patient like who's already diagnosed?
That's a very interesting question, because not many people know that not all prostate cancers need treatment. You can actually just put the patient on surveillance and delay the treatment for as long as possible. So that not many people discuss also, because Indian scenario, what I've noticed, once you made a diagnosis of cancer, if I start talking to them that there is an option where you don't need to treat your prostate cancer, I can keep you on close follow-up and I'll be monitoring it, they're not comfortable with that. I have a cancer, why you're not treating? This is the first question I get it. So yes, there are a certain sect of prostate cancers, like very low grade. We usually in medical terms we say Gleason score, a low Gleason score, the tumor is still inside the prostate. When you do biopsy, very minimal amount of biopsy is involved by the prostate. So such kind of a thing. So if all these criteria are met, there is no harm in putting the patient on active surveillance. Now that surveillance is important, because it's not a random follow-up. You keep testing his PSA on regular intervals. Once a year, you'll have to get a examination also done, a rectal examination done. And once in 1.5 years, you also do an MRI, and you also do a biopsies. So the patient also has to accept all this. You do a distal rectal examination, which is not comfortable. Then you do an MRI, which should be okay. But anything doubtful in that, we go ahead and do a biopsy. So you may have to undergo multiple sessions of biopsy. So it's a shared decision making. You can always say it's a good option to delay the treatment, but only provided only if the patient is okay with this. Multiple biopsies, multiple scans, multiple examinations, hospital visits, all these things.
Exactly. So basically the take home message is, even if you have prostate cancer, don't get worried. Keep yourself under follow up and should not be worried about. So let's talk about something more aggressive, like something like bladder cancer and kidney cancer, mostly, which is RCC, renal cell carcinoma. So what's your take on like the recent advances, or what the patient should be watching out for?
See, bladder cancer, again, unfortunately, we do not have any tests that we can detect it at very early stage. So there is nothing called screening for bladder cancer. But certain people can be more vigilant because there are risk factors for bladder cancer, like people who smoke a lot have an increase. That's the most common risk factor for bladder cancer. And apart from that, people working in certain industries like rubber industries, metal industries, they are more again prone for these because of the chemicals in that. And long-standing infections, urinary tract infections, can also lead to bladder cancer. So any person having these symptoms has to be more vigilant. But apart from that, just continuously testing all people for bladder cancer is not an option. And another unfortunate thing about bladder cancer is, even if a patient has a localized disease, so we divide them into 4 stages, 1, 2, 3 and 4. So 1, 2, 3 we say it is localized. And you treat them with surgery successfully, unfortunately 30 to 50% of them will have their cancer back. So that is why, as you said, bladder cancer is aggressive, and that's very unfortunate, this thing about it. So how we go about bladder cancer is, ideally we have to start off with chemotherapy. especially I'm talking about only muscle invasive ones. There are again less aggressive bladder cancers which even don't come to a medical oncologist. They're dealt by urologists completely. Yeah. So I'm talking about the ones which are aggressive which come to the medical oncologist. You give chemotherapy first, then take up for surgery. And now not recently, there is more and more scientific evidence, and doctors are adapting to it also, where if a patient does not want his bladder to be removed, because you do bladder surgery, remove it completely, and so that will be a problem for him because he'll not be able to pass urine normally. So now if a patient wants his bladder to be intact and no surgery has to be performed, there's something called bladder preservation, where you give chemotherapy and radiation and try controlling the cancer and then avoid surgery altogether. Because as you know, you'll be performing a lot of bladder surgeries. It's not an easy surgery. And the morbidity, I mean, the recovery after that also is not so great.
Like you
recovery
said,
from bladder
recurrence rate is quite high, and by the time the bladder tumor comes to us, we already have resected it. It has already become muscle invasive, and when we can't deal with it, we push it on to take care of it now.
But the thing, and again, the science, the field has been evolving very quickly in bladder cancer also. And now the most recent addition to bladder cancer is immunotherapy. There's something called antibody drug conjugate. These all are targeted medicines, where they go and try killing the cancer cells very specifically and sparing as much as the normal cells. So before all these advancements, final stage bladder cancer probably used to live for 6 months or 1 year. That was the timeline. Now those patients also very comfortably are living for 2 or 3 years, even beyond that.
Then coming to kidney cancer, would you want to be like specific about anything to watch out for other than like blood in the urine, hematuria?
Blood in the urine is the most common way they come to it. Apart from that, if you have a flank pain for a long duration, unexplained, usually they meet multiple doctors. They go to ortho, neuro and all because the pain is in that region and it is not getting resolved, and get checked for your kidney cancer as well. But again, kidney cancer is a different ballgame altogether. It is very diverse. Unlike bladder cancer, there are a lot of different types of kidney cancers which can come. But most common, 90% are the clear cell ones, what we routinely see in the clinics. And fortunately, they're not as bad as bladder cancers. If you detect them at an early stage, the cure rates are very, very high. And you don't need to remove the entire kidney also. If you detect it very early, only by removing part of kidney also, you'll get away with the cancer. And if it is going beyond that, that is when they come to the medical oncologist. Even final stage kidney cancer also not to be worried about, because with the medicines that we have right now, long-term survival is very much guaranteed. Around 70-80% of patients have very good long-term survival, the medicine what we have.
So Dr. Saadvik, coming to testicular cancers, what are the catch points you would want to tell our viewers what to watch for, and what age group does it affect, and what are the side effects of treatment?
So coming to testicular cancer, what is important to know is there's certain risk factors. So if these are there, then there's a very high chance at a later age that you can develop testicular cancer. The most common among them is cryptorchidism. So cryptorchidism basically means if the testis has not come into the scrotum. It is when the child is born, it's usually a testis in the abdomen. Slowly it has come up down to the scrotum. If that does not happen, that is carries the highest risk for getting a testicular cancer. Then after that, family history. If a brother has testicular cancer, then the other brother can also get testicular cancer. And the third thing is, a patient who's already got a testicular cancer will always be at a risk of getting cancer in the other testis. So these three things is what they have to remember. But if they had cryptorchidism when they were at their childhood, they should be at a regular follow-up with the urologist, because testicular cancer commonly occurs within the ages 15 to 35. It is not like child is born with cryptorchidism, he'll have cancer immediately. It's not like that. So it occurs at a later date. So that 15 to 35 years bracket is when they have to be very vigilant, when they have the risk factors. And another problem with the testicular cancer is this particular age group is when people are settling in their life. They're completed their education, they're getting new jobs, or they're getting married, planning family, and this. So it's a very stressful, mentally stressful age group when the cancer hits them. But the brighter side of testicular cancer is 90% of them can be completely cured. So if the tumor is still in the testis, then almost you can say 98-99% of them can be completely cured of their cancer. If the cancer started to spread outside the testis, it can spread to the abdomen or chest, and whichever area it is spread, it is still curable. So one good thing about this, you don't need to lose hope in testicular cancer. The cure rates are very, very high. Even if it is spread to different parts in your body, 90% of them can be completely cured. That is a good part about it. And coming to the long-term follow-up of these patients, they live long, no doubt about it. So post your chemotherapy, they are at risk of certain side effects. One thing what we're worried as an oncologist is that they can have cancers again. If you're given radiotherapy as part of the treatment, then they can develop cancers in any of the abdominal organs. And chemotherapy makes them prone for blood cancers. That is not immediately, but 15 years, 20 years down the lane. The risk is very less, only 1 to 2%. But still, it is important that the patient is aware of it. Because 15, 20 years, you never know that you'll be following up the patient, or the patient has moved to a different city or country altogether. So you should educate them that this risk is there. Be on a regular checkups, and if any doubt is there in your regular blood report, immediately consult with an oncologist. Apart from that, when they receive chemo at such a young age, over a period of time they can have even cardiovascular effects, the chemo affecting their heart also. So it is important for them to maintain a very healthy lifestyle. Once they're diagnosed of it, get treated. Once the treatment part is done, they have to get back to a normal life, and then they have to maintain a very healthy lifestyle. That is being active, exercising, eating a healthy diet, and being on a regular health checkups and this kind of thing. But as an oncologist, what we don't deal with these patients in terms of side effects is infertility. So already one testis is affected by cancer, and they'll be going through this radiation, chemotherapy, surgery, all form of treatment. So their chance of being fertile reduces considerably. So even before we start our treatment, we get an opinion from urologists how to deal with this infertility. So what is your take? How do you deal with these patients?
So coming to the starting point of it, understanding testis, it's usually missed at birth, especially when the birth is in a center where there's no daya or there's no pediatrician. Parents sometimes miss it. So it is with the patient, it is essential for the parents as well to watch the child till he's growing up, till he attains a certain age, to make sure that both testes are in the scrotum. If they're not, then go see a doctor immediately. And when we get a UDT, we try to understand the testis. We try to repair it with a orchidopexy before 2 years of age. Coming to infertility, depends on the staging again of the cancer. If it is growing fast and it is a risk to the life of the patient, then we say go ahead with the treatment first. We think about fertility later. But if the patient is fertile, we try to preserve this semen immediately. If the quality of the semen is less, we try to improve the quality a little bit with the help of medication or supplements, then preserve it. And coming to the libido part of it, once the patient undergoes orchidopexy or orchidectomy, removal of the testes, and chemotherapy, the libido might go down. So we can always supplement this with artificial testosterone for a healthy sexual life in the future for the patient.
So you're saying that if treatment for cancer is not very immediate, then you'll be concentrating more on infertility, right? So what is that window? Like how long does it take for the semen preservation and get an analysis done and say that we can go ahead with cancer treatment or the surgery? So what is the usual timeline for that?
Usually we just do an analysis with 3 days of abstinence. If that is normal, then we straight away go ahead with oncological management, because we don't want to keep the patient with us for long. We want to get a healthy analysis and just give the patient to you to treat it.
So in 3 to 5 days time, we can get a healthy sperm and we can start with the cancer treatment.
Yeah, as to where the patient is heading.
And coming to the testosterone use in long-term survivors, how do you follow them up? Like what side effects do you look at? Will you be educating the patient, and what you will have back of your mind that what can testosterone cause when you use it for a prolonged period of time?
There are a couple of things which you will watch for. As these patients should be young, we'll be starting testosterone early. So the serum PSA level, because testosterone causes causes prostate cancer. So you have to keep monitoring the PSA levels and the liver function test, because these are broken down metabolically by the liver. So depending on the molecule which you are given, usually earlier on they used to be given oral molecules, but now we have pushed them onto injectable molecules, and certain patients adapt well to certain molecules. So testosterone is just not testosterone. It is of different compounds as well, like enanthanate, cypionate, and andeconate, which half-life is also variable from 2 to 3 days to up to 2 to 3 months. So depending on the patient, what the patient wants and what is best for the patient, we give that accordingly.
And this is completely offbeat, not related to testicular cancer. We get to hear a lot of bodybuilders and gym goers also use steroids and testosterone, and there are a lot of young people dying of cardiac conditions in the gym.
So the catch here is like what we prescribe is testosterone replacement therapy. So it is basically the testosterone the body is used to, and what we're giving to the patient to replace it, not to go above and beyond it. What dosages these bodybuilders use and for the prolonged periods of time they use is very dangerous. They use maybe like 4 or 5 times higher. The testosterone levels, which is the upper range, is about 1000 milligrams. Their levels are around 5,000-6,000. So they're at a higher risk of prostate cancer as well. With this, the blood becomes thicker, so higher risk of stroke, cardiac events. And with this, these off-label use drugs which are used, they're not just testosterone, there are other hormones as well, which are used on cattle, which are used on horses, which the latest bodybuilders kind of use, which is very harmful. These are like 300-400 times more powerful than regular testosterone. So these compounds are very dangerous, which are just prescribed by like any gym you go into. There would be a shady trainer.
What you're saying is there's no control on this, like they can get the medicine without a doctor's prescription. They can buy it from the pharmacy directly.
These medicines are not produced in India. They are
imported.
Okay. So from Russia or from China, from wherever. Like I would not want to comment from where they come from, but they're not produced in India.
Okay, so they don't need a doctor prescription. They
Nothing.
can applicate it.
Okay, now let's come to something more interesting. The most important part: lifestyle, health, supplementation, diet. What diet would you prescribe? Like the West has suggested, like a ketogenic kind of a diet, Mediterranean kind of a diet for cancer patients, less in sugar. So that one basic principle behind that, which non-medical practitioners say, is that if there is less glucose into the cell, it grows less. So ketogenic or long fasting, anything you want to...
If you ask me, a simple blanket statement, what I can put is there is no diet that can cause cancer. Or there are food particles like processed meat and such things which can cause cancer, but there is no blanket diet which can say that cancer will not come. There is no cancer diet that can prevent cancer. Mm-hmm. But saying that, it is very important to maintain a good diet, because the chance of cancer can slightly be reduced. Even if it is not prevented, it can be reduced. And coping up with cancer, it will help. And cancer is not the only thing which can affect a person, right? There's something like cardiac conditions, liver condition, other things also. So overall health point of view, also maintaining a healthy diet is very important. And as you mentioned, in multiple diets, Mediterranean, ketogenic and all those things, I personally feel that diet has to be individualized. Just following one diet blindly will help a lot of people, but it may not help everyone. Exactly. Personally, even I was obese, overweight person. And then I tried intermittent fasting, didn't help me. I tried the Mediterranean diet, didn't help me. Ketogenic diet, all those things didn't help me much. That is when I realized it has to be individualized. People say eat rava idli, it will help you. For me, if I ate a rava idli, my sugar used to spike up to 180. And so it was not suiting my body. Probably it is suiting another person, but it's not suiting mine. What I usually suggest my patients who come to me, cancer patients regularly, is there's something called continuous glucose monitoring.
Yeah, I have it on.
You already have it on.
I see you wearing a ring, I'm wearing a strap. So, like when I was also trying to lose weight, I tried idli. Idli was not helping.
Idli doesn't help at all.
Fasting helped me, and fasting helped me lose weight.
Yeah.
So
idli is all carbs.
Yeah, so it's big misconception that carbohydrates are going to help you lose weight. They're not going to help you lose weight, especially Indians, because our diets are more starchy compared to the West, and even the carbs which we use are either millets or like very starchy, like rice or anything.
The thing with our diet is the protein content in our diet is pretty low. And especially if you want to lose weight, protein plays a very important part in our diet. At least 40% of a meal has to have some kind of protein. Another 40% will have to have fiber, which has your vegetables or any form of fiber, nuts or anything. Only 20% if you restrict your carbs, that is better. And that too, if you go with healthy carbs, that is even more better. Like your millets are a source of good healthy carbs. Rice is not. Unfortunately, South India, rice is a...
You can't live without rice. Yeah. What about exercise? How much do you want to do? What kind of exercise do you want to do? Do you want to mix and match? And
so there are recommendations from various societies for how much you have to work out on that. WHO says 150 minutes in a week of moderate exercise. If you're doing a high intensity, somewhere around 75 minutes is enough. But keeping the recommendations apart, I would suggest every day having some kind of physical activity.
Enjoy yourself, basically try to keep yourself active. And
it's not like you only have to go to the gym and do workout for a healthy lifestyle. A sport is also enough. You like cycling is also good, or badminton, cricket, or any kind of sport also good.
I think for longevity, mix and match is going to be good. A couple of days of weight training, couple of days of maybe you go for a run or a walk, or like you want to de-stress, go for a walk near a water body, a hill or anything like that. Which
human body is not meant or made to be for a sedentary lifestyle.
Exactly.
It is meant to be more active. But unfortunately, we have moved into that sedentary lifestyle, and that is why all these lifestyle diseases which have come in.
Coming to supplementation, what is the one supplement that you would advise everyone to take?
Not really. I would ask them to more stick to their diets properly, because supplementation have their own benefits and risks, and we still do not know what supplementation will fully help us and which may harm us as well. For example, if you see people say taking multivitamins is beneficial. Then there is vitamin E. A lot of people these days online also they sell a lot of vitamin E and all. Initially they thought it will help as an antioxidant, reduce cancer and things like that. So it is a very dicey thing. Or to adhere to a very healthy diet, and if you have some nutritional deficiencies in spite of that, then to cover that deficiency, give a supplement.
A lot of youngsters who go to the gym talk about creatine. So creatine also comes in different forms. I feel it is like a good supplement to be taken whenever you want to take, if your kidney function is good. What I have felt like the Indian gut is not so accustomed to creatine monohydrate, and the recommended dose is about 5 grams, which is in the Western world. We will not be able to tolerate that, and we'll have bowel issues. What's your take on creatine, and what kind of creatine would you want to?
As I said, I'm not a very pro person for supplements and all. Creatine, saying that I did use during my gym days, but as a recovery protein, not to build your muscle, as a recovery protein. But telling that, I'm no expert in that, and I don't recommend also to others. I try pushing more natural things into them than the artificial.
What about magnesium?
Studies do say magnesium, melatonin, all these do help in...
melatonin should not be used in males because it drops the testosterone levels.
Is it? Okay.
So big catch point for all the males watching, like, don't take melatonin.
Dropping testosterone may help with prostate cancer.
Yeah, but that is for the not when you're young.
So, Dr. Khizar, this elderly people, now as India's life expectancy is increasing, we'll have a lot of people in that age group, elderly age. So, what are the hormonal issues they can have, and how do they commonly come and consult with you?
So, if you see, male aging peak is at 24 years of age. So you start getting old at 24 years.
Okay.
But you get to feel it later on in life. So people who are getting low testosterone levels, or andropause as you may call it, they might throw other symptoms like cardiac disease, diabetes, fatigue, loss of memory, irritability. All these could be causes, lack of interest in work, loss of memory. Other than the sexual problems which they might be having, which might be erectile dysfunction and premature ejaculation and loss of muscle mass. So when a patient is facing these problems, it is ideal in a master health checkup to do serum testosterone in a patient who's above 40 to 50 years of age. So if it is low, then we try to keep it in the mid-range. We don't want to keep it at 1000. We want to keep it at 500, 600. And once the patient achieves that with supplementation, try to bring it down and wean off the patient and try to just keep the patient on an active lifestyle, so that the side effects of testosterone therapy or replacement therapy should not affect the prostate cancer or the liver function of the patient. Coming to the premature ejaculation and screen time point of it, males face two hormonal imbalances in their life. One is at puberty and one is at andropause. So at puberty, probably because of lack of a sexual partner, they opt for more options like pornography, masturbation. This leads to premature ejaculation in the males. And with this, in both partners, it might lead to higher expectancy and the feel in both partners that they're probably not able to deliver. Even if they don't say it to the partner, they're not able to deliver to that level which the partner is expecting. Many patients come, they feel that they have erectile dysfunction or premature ejaculation, but when they really don't have it, it's just that it's a higher expectancy which they are facing because of the pornography or the digital whatever sources they are using.
We've received a few questions from our audience and we would like to address a few of them. So the first question is, can men get breast cancer? So there's a common misconception that only female can get breast cancer, but that is not true. Even men are prone for breast cancer, especially in the elderly age group. Next question is, does heat from laptops affect male fertility or testicular cancer? So testicular cancer part, no, there is no proven evidence saying that heat from laptops can cause testicular cancer. With respect to fertility, I think Dr. Khizar is more qualified for that question.
Yeah, there's no research on this, but like how Dr. Saadvik is addressed, the scrotal temperature is supposed to be 1 to 2 degrees lesser than the abdominal temperature. So anything which is radiating heat to the testis could be harmful.
Right. So is bigger prostate always a problem, Dr. Khizar?
Not really. Benign prostatic hyperplasia was the older term which was used. The newer term is benign prostatic obstruction or benign prostatic enlargement. We treat the patient only if he has benign prostatic obstruction. If he has enlargement, no symptoms, no treatment needed.
And is erectile dysfunction only a sexual issue?
No, it is a multifactor issue. 90% of it is psychogenic.
Then does usage of mobile phones cause brain cancer? There is no clear evidence. There are few studies saying that using mobile phone increases the chance of getting brain cancer, and there are few studies saying there is no relation between use of mobile phone and brain cancer. But to be on safer side, not only for brain cancer, in general for better mental health and better sleep, it is better to reduce the usage of mobile phones. Do genetic mutations play a role in male infertility?
Yeah, a few genetic disorders patients are born with could affect male fertility.
And is low testosterone the main cause of fatigue in elderly men, especially?
Not really. Fatigue could range from electrolyte imbalance to low testosterone. So it's a very wide range and it's a very broad spectrum question. So first I would say the most common cause of fatigue is electrolyte imbalance.
And then is low sperm count the only cause of male infertility?
Not really. Even if the sperm count is normal and if there is blockage in the passage of sperm, if there is bladder outlet obstruction, it could also cause infertility in strictures, etc.
And pelvic floor exercises, how are they useful for men? Are they useful? And if they're useful, how are they useful?
Yeah, post prostate surgery, especially a TUR or a enucleation of the prostate or a radical prostatectomy, pelvic exercises do help in recovery and continence of the patients.
Finally, it is can obesity cause cancer? Yes, obesity is linked to not one, multiple cancers. Most common are pancreatic cancer, kidney cancer, and even colorectal cancers. So always maintaining a healthy lifestyle with which is less sedentary and more active is better.
I think we've come to an end here. So it was a great discussion. I think patients have got a lot of information and a lot of questions have been answered which would not have been answered usually. So a lot of patient information material has been given out. So thank you for your time. And
Thank you, Dr. Khizar, for a wonderful discussion and a lot of enlightenment regarding men's health.
And stay tuned to our podcast for more information about different ailments and illnesses.